Good morning, everyone. Welcome. It's great to see we've got a number of people that are online as well. We'll be monitoring the Q&A or chat online, so for those joining us that way, feel free to put in your questions. It's a great way to start Saturday here at SWOG. We've got 3 of our great active trials that are going to be presented, and we look forward to your comments and thoughts around that. So pleased to have Guru kick things off today, and thanks for your attention.
Thank you, Tom. So I'm here to talk about the SWOG 2011 trial. This is the randomized phase 2 trial examining gemcitabine, avelumab, and carboplatin combination versus no neoadjuvant therapy preceding surgery for cisplatin-ineligible muscle-invasive urothelial carcinoma. We also call this the SWOG-GAP trial. So in the neoadjuvant setting, cisplatin-ineligible patients, as we know, there is not an established standard of care. So neoadjuvant gemcitabine and carboplatin is actually active and tolerable in muscle-invasive bladder cancer. So there is data out there in the form of retrospective studies that have compared neoadjuvant gemcitabine carboplatin versus no neoadjuvant therapy, and in a propensity score matched analysis, there is an overall survival and PFS benefit actually in this retrospective analysis. Also, when you look at pathologic CR rates across retrospective studies, there is a path CR rate of 16.3% to 30% with gemcitabine carboplatin. So we, of course, know that neoadjuvant immune checkpoint inhibition with various PD-1, PD-L1 inhibitors or combination immune checkpoint inhibitors are active in the neoadjuvant setting with a path CR rate in the 30 to 40% range. Of course, neoadjuvant chemotherapy plus immune checkpoint inhibitor combinations have also been evaluated, as we all know, and there is a promising pathologic complete remission rate and a less than P2 N0 downstaging rate with these regimens, which has, of course, led to numerous phase 3 trials ongoing in the neoadjuvant setting. Now, what we know is, of course, also that the gemcitabine platinum combination plus PD-1 L1 inhibition has shown an inkling of benefit in this first-line metastatic disease trial, where gem platinum plus atezolizumab improved PFS in the IMvigor 130 trial. We also know that this combination with chemo-IO combinations have been safe in cisplatin-ineligible patients. And in this setting, actually, avelumab has also been used in combination with chemotherapy in the neoadjuvant setting in a phase 2 study, phase 1, phase 2 study, and it looks safe and with a signal of efficacy. Now, of course, all of these data have led to numerous phase 3 trials in the neoadjuvant setting. As we see in the cisplatin-eligible space, there are numerous trials looking at combination cisplatin-based chemotherapy plus a PD-1 or L1 inhibitor. And also in the cisplatin-ineligible setting, various immune checkpoint inhibitors are being looked at. And of course, we also know the EV plus Pembro is being looked at in one of the arms in the phase 3 study, which also has Pembro single agent or Pembro plus EV. Now, some of these trials, the one I show you there, the BMS trial, has actually turned up negative for the combination with the BEMPEG compound, the IL-2 agonist. So we have seen some negative data actually in the neoadjuvant setting in this trial by BMS. So the background for this trial is that in the neoadjuvant setting, cisplatin-ineligible muscle-invasive urothelial carcinoma, we have an unmet need. These patients go to upfront surgery. There is not an established chemotherapy in the setting, as we have for cisplatin-eligible patients, of course, with MVAC or gemcitabine cisplatin. Now, pathologic complete remission and disease-free survival are associated with survival in muscle-invasive urothelial carcinoma. We have shown this in the setting of neoadjuvant chemotherapy as well as adjuvant chemotherapy. In the neoadjuvant PD-1 L1 inhibition setting, we don't have high-level data on this, but there is an inkling of association of path CR with benefit with the neoadjuvant pembrolizumab in the neoadjuvant PURE study, as we know. So neoadjuvant PD-1 L1 inhibitors and carboplatin-based chemotherapy are active, and their combination is safe and feasible. And I would also add that this combination has toxicity advantages over EV plus immune checkpoint inhibition because of the absence of neuropathy and skin toxicities that is seen with EV. So we hypothesized that the combination of gemcitabine, carboplatin, and avelumab would be safe and would improve the pathologic complete response rate and long-term outcomes compared to conventional upfront surgery alone in cisplatin-ineligible muscle-invasive urothelial carcinoma. So the objectives of this randomized phase 2 trial were to compare pathologic complete response with the combination of avelumab, gemcitabine, carboplatin versus no neoadjuvant therapy for cisplatin-ineligible muscle-invasive urothelial carcinoma, with secondary objectives of toxicities, resectability rates, surgical complications, event-free survival, overall survival. And we also had banking objectives to bank tumor tissue, blood, and urine, and to look at correlative studies. So this is the single slide showing you the design, the SWOG 2011 trial, of course, a randomized phase 2 trial, like I mentioned before. And the eligibility, if you go from the left-hand side to the right-hand side, is muscle-invasive urothelial carcinoma. And the trial includes both upper tract and bladder, I will add, so clinical T2 to T4A and 0, and cisplatin ineligible by conventional criteria, and predominant urothelial component, and no small cell component. The patients are stratified for clinical stage, performance status, and creatinine clearance. And on top, you see the standard arm, patients go to upfront surgery. At the bottom, gemcitabine, carboplatin, avelumab is the experimental arm. I will also add there is no stratification for PD-L1 immunohistochemistry, so there is not the central review that sometimes delays patients getting on treatment. Patients get anxious waiting, which we've seen actually with many of the ongoing phase 3 neoadjuvant trials where there is stratification with central PD-L1 testing, which delays treatment actually in many cases. So patients go to surgery, which can be radical cystectomy or nephrouretrectomy or uretrectomy. And in the adjuvant component, many of the ongoing phase 3 trials have an adjuvant mandated component of adjuvant continuation of the immune checkpoint inhibitor. Now in this trial, we have left it open to the investigator to give adjuvant therapy or not, and up to investigator discretion. So adjuvant nivolumab, for example, would be allowed actually in both arms of the trial, of this trial. So that is nice because there is it's not like we're denying perioperative immunotherapy to these patients. And post-op monitoring is as per convention. The primary endpoint is pathologic CR with the secondary endpoints noted there, including EFS, overall survival, toxicities, and correlative endpoints. The trial attempts to detect an improvement in PathCR from 15% for the standard arm to 35% for the experimental arm. There is 1:1 randomization, and we need 178 evaluable patients. So the eligibility, as I said before, is muscle-invasive bladder cancer or upper tract urothelial carcinoma, in which case we need high-grade disease plus a mass on imaging or ureteroscopy. And we do need predominant urothelial component. Patients need to be candidates for surgery and cisplatin ineligible by one of the standard criteria that we are aware of, noted there. And the chemoimmunotherapy regimen is essentially the combination of gem-carbo plus avelumab. Remember, gem-carbo is day 1, day 8, Q3 weeks, 4 cycles. The avelumab is every 2 weeks, given 6 times. And the AUC for the carbo is escalated to 5 from cycle 2 if no toxicities with AUC 4.5 during cycle 1. And remember also the avelumab needs pre-medication, of course, like with acetaminophen and diphenhydramine. I mentioned the statistics before. I will not repeat that. The correlative studies include storing tumor tissue, blood, and urine. And I mentioned radiographic images banking here. That is still something that's going to be worked on in the near future for radiomic studies. So this trial has had accrual challenges. We've had 5 accruals since activation in October 21. So there are several reasons for accrual challenges we've noted. So one of them is that there has been a delay in opening and activation of the trial at several institutions. And in fact, some institutions were still activating the trial earlier this year. So that's late into the course of the opening of the trial. And There was a requirement for documented bimanual examination under anesthesia, under eligibility criteria. So this has now been removed with the recent amendment. So this amendment is activated early in April. So that has become a recommendation under the procedures, and it's not a requirement. There could be competing industry-sponsored trials, and many of these trials are actually either completing or about to complete, so hopefully there will not be the competing trial issue in many of these institutions. The design of the trial of chemo IO versus no neoadjuvant therapy is sometimes challenging, and especially patients who would not might think of the arm going straight to surgery as being not as attractive as the chemotherapy plus immunotherapy arm. But I will point out that the trial does not disallow immunotherapy in the adjuvant setting and does allow adjuvant nivolumab or any other regimen if you feel appropriate in the adjuvant setting. And the chemo IO regimen itself, gem-carbo avelumab, might be thought of as not so exciting. However, this trial, I will point out, is the only trial that still does not require a specific adjuvant component and allows nivolumab. I would also point out that gem-carbo has significant toxicity advantages over some other regimens that might be perceived to be more active. For example, the EV-pembro regimen, which does have significant toxicities and might not be appropriate for many patients. So these amendments have been made and now active since the beginning of April. So we now have relaxed the timeline to register. So muscle-invasive disease is required within 120 days before registration. And a TURBT or ureteroscopy is needed within 70 days. So that is relaxed from before. Bimanual exam under anesthesia is removed as a requirement for eligibility, and now it's a recommendation under procedures. And we've clarified some other points in the protocol to improve the clarity regarding holding of drugs. Essentially, you can continue the regimen that is not causing the toxicity and without having to stop the whole regimen when you have a toxicity, for example, specifically related to avelumab or specifically related to the chemotherapy. These are my contact details, so I guess I'll take some questions now.
And we're monitoring things online too. There's about 30 people online, so if you have questions, feel free to come up that way as well. Any questions for Guru? So Guru, I'll ask this, with the avelumab dosing held, is there some minimum amount of avelumab that needs to be delivered for the trial considerations to stay on?
No, there's not a minimum amount. So if you have a toxicity requiring you to stop the avelumab, you can continue with the chemotherapy and finish up the course. So there is some investigator discretion, of course, that is allowed here.
Great. We'll invite Sarma to move towards the stage here. Any other questions for Guru? Well, it's good to see a little traction developing with this and the amendments going through with those changes, so thank you very much. And again, I would say for folks that are online, it looks like there's 30 or so. Feel free to put questions in the chat, and we'll be monitoring those as well.
Good morning, everybody. Thank you for being here today. This is an extra session for us to review some of these studies for you and with you in hopes of getting more sites to open the studies. This particular trial, 1937, we have opened it a couple of years ago, but accrual has been poor, and participation among the members in SWOG and other cooperatives have also been low. So I would like to just ask you to consider this study. I'll go over the details of the study for you here today. This is becoming a bit more relevant with the changes in standard of care, and I'll walk you through that. So this is the phase 3 randomized trial of eribulin with or without gemcitabine. So there are 2 eribulin arms. versus standard of care for patients with metastatic urothelial carcinoma that are refractory to immunotherapy, or they were deemed ineligible for immunotherapy. So that was the idea, that you would have these metastatic patients. They get cisplatin and then immunotherapy and then enfortumab vedotin. And when you're at that point, then this would be a great option for these patients. Recently, in April of this year, we had a new combination become available for our patients. This is enfortumab vedotin plus pembrolizumab for cisplatin ineligible patients that are treatment naive. So this combination received accelerated approval based on cohort K of EV-103, and I'm sure you're all very familiar with that data. So I'm moving the slides here, but they're not moving there. So is there another window I have to go to? All right, so this is what the current landscape looks like after these changes. We can see that again, we are back to looking at cisplatin ineligible or cisplatin eligible patients in frontline. If we have cisplatin eligible patients, then that is the preferred treatment option. And if our patients are cisplatin ineligible, then we do pembro plus EV. Once we are past frontline, especially for patients who are cisplatin ineligible after pembro and EV, we really have limited options. Do we really go to a carboplatin-based regimen after pembro plus EV, or do we do sacituzumab govitecan, which has accelerated approval for post-immunotherapy patients? I would argue that SWOG 1937 is as good an option as the other two, because sacituzumab govitecan is in phase 3 trial against standard of care docetaxel in this setting. Data for sacituzumab govitecan for patients that have already received enfortumab vedotin is very limited, and from what we know, based on the JCO paper, in that study they had only 10 patients, one of whom actually responded. So based on that, it may be about 10%. And there was a series at ASCO GU this year from Hopkins that showed they had 3 out of 18 patients respond to sacituzumab govitecan after having received enfortumab vedotin. So we don't have great options when we get to that point. And I think having 1937 on the table for these patients, I think it's a very, very good and reasonable option. If patients are cisplatin eligible, then they walk through the same process of getting cisplatin and then pembrolizumab and then EV. And then we'll be ready for SWOG 1937. If we have resectable patients who get cisplatin-based chemotherapy before surgery, and then in adjuvant setting they get immunotherapy, then these patients are kind of fast-tracked into getting enfortumab vedotin in metastatic setting, maybe even in first-line metastatic treatment because they received immunotherapy already. And then they'll be ready for 1937. So eribulin, there were 2 phase 2 studies that we did as part of California Cancer Consortium. One was eribulin monotherapy, and one was gemcitabine eribulin combination. The eribulin monotherapy data, you can see that this was before we had immunotherapy as an option. So the median survival for these patients was 9.5 months at the time. That was really impressive number. And response rate of 34.7%. So these patients were previously treated. Some of them got docetaxel even after cisplatin-based chemotherapy. On the other side of this table, the gemcitabine eribulin, that's for earlier line of treatment. This is for cisplatin ineligible patients. And these patients were, at the time, they really didn't have any option other than just monotherapy if they could tolerate it. They got the combination, and response rate was 50%. So that was a great result, and median OS was 11.9 months. In comparison, if you remember immunotherapy for cisplatin ineligible patients in frontline setting, if you just in your mind compare the results of that study to those trials, you'll see that that's why we are so interested in this gemcitabine eribulin combination. We had responses that were really more than what we expected. We had patients with visceral metastases, liver involvement, who had response on both studies. So again, this is the background for this trial, why we think it is important to have this. The current design of the study is previously treated metastatic urothelial carcinoma, RECIST-defined measurable disease, either post-immunotherapy or ineligible for immunotherapy, adequate organ function, and we allow performance status of 2. These patients are randomized 1:1:1 to standard of care, which at the moment is docetaxel, paclitaxel, gemcitabine versus eribulin alone versus the gemcitabine eribulin combination. Based on the feedback that we have received from the group and the discussions and in response to the changes in standard of care, we are proposing an amendment to CTEP to simplify the eligibility criteria and also simplify the design of the study. So now that Pembro EV is available, so we can have patients that come to the study in earlier lines of treatment. We don't prescribe any certain number of prior lines of treatment, and the sequence is relaxed. As long as the patients are previously treated and they have received immunotherapy or are ineligible for it, they're welcome on this study. We do not require platinum-based chemotherapy either in frontline or in a subsequent line. ECOG performance status still 2 is allowed. In the standard of care arm, even though sacituzumab is not a great option based on what we know in a post-enfortumab vedotin setting, because some of the clinicians had equipoise concerns, we are allowing that in the standard of care arm. So the standard of care arm is going to be sacituzumab, govitecan, docetaxel, paclitaxel, or gemcitabine. And the experimental arm, we believe that gemcitabine eribulin combination was going to outperform eribulin alone combination. So because of the poor accrual, we are simplifying the design and we are going with the best arm that we thought was going to be the winner. So now it's going to be gemcitabine eribulin, the experimental arm. So 2 arms, standard of care versus gemcitabine eribulin, 1:1 randomization. And this way, because we are not doing potentially 3 head-to-head comparisons, that also allows us to reduce the sample size. So we're going to have this study probably with a sample size of 154. That would reduce our accrual pressure to 3 a month. But we still have to get there, and so far the best that we have done has been 1 month of 3, and the rest of them, they've been maybe 2 patients per month. So we do need your help very much. I'm going to stop here. These are the colleagues and investigators that have participated on the study. I have their names there, and I also have their institutions. I very much appreciate your support, and I hope more of you will join this study and we can do much better and get the clinical question answered, whether eribulin has a role in the treatment of urothelial carcinoma. Thank you very much, and I'll take any questions.
Thanks for the presentation. And again, anybody that's online, we've got about 36 people online. Feel free to ask a question that way. Sarma, that's an interesting space right now clinically with a lot of changes in this space and I would just say, maybe want to comment on this. There's a paucity of data, I think, in this post-EV Pembro and sort of what comes next. But do you want to talk at all about what we know about that space or add any additional comments on that, this post-EV Pembro clinical space?
So as far as I'm aware, there are no regimens or agents that are ready to be in a phase 3 in post-EV setting other than sacituzumab. And sacituzumab, the current study is not really post-EV, so that question is going to linger for a while. It is a good agent. If you don't have any option, I would do sacituzumab over docetaxel or gemcitabine. I think those are completely, that completely makes sense. But we also have this phase 3 study looking at an agent that has excellent phase 2 data, even before the age of immunotherapy. So I would argue that there is equipoise to choose SWOG 1937 if your other option is sacituzumab govitecan or a phase 1 study or any phase 2 study. So with this change, doing enfortumab vedotin and pembro in combination together before carboplatin, I think we will get there a lot faster than we used to. We had to do carboplatin, and then we could do pembro, and then we could do enfortumab vedotin. Doing pembrolizumab before enfortumab has always been a little bit of a puzzling thing for all of us because we are doing something with response rate of 20% or so before doing something with response rate of 40%. So I suspect at some point maybe we'll have some sort of approach to doing pembro EV together even after cisplatin-based chemotherapy. We will see, but the larger point is that we will run out of options quicker than before, and we'll find ourselves looking at phase 1s, phase 2s, or even just sacituzumab or docetaxel.
I think these are very nice changes.
It says working now.
Sorry?
I think the mic's working now, if you hold it up.
Hello, yeah. So I think these are very relevant changes, and it will increase accrual, especially allowing sacituzumab in the control arm. Even though we don't have data for sacituzumab after EV therapy, that has become a default second-line therapy. So I think it will pick up.
Thank you, Neeraj. I completely agree. That's our hope, and I hope that we can convince more of you to go back to your institutions and put this in your on the list of trials that you'll open.
Hello,
this is a SWOG study. It should open very quickly. One thing that I can add is that now that we intend to do this amendment, which is hopefully going to go to CTEP soon, we'll have a period of closure, temporary closure for the study. We don't want to put patients on a study that we know we're going to change and drop an arm. So that's a good hiatus for all of you to work this study within your systems. Feel free to shoot me an email and ask any questions about the study. I'm happy to help you open it and help in any way. So please reach out to me.
Wonderful. And I would just say, I see that for our next presentation, Olka just sent me a chat message. She's online to our great AV staff in the back. Would like to share her screen in just a moment. So our next presentation will be on probe. Sorry, I would just comment, I think we've got a few accruals there from Colorado. We were able to open this, I think, November? You can remind me.
Yes, very quickly.
And we've
put patients on this study. Yeah. So these patients are out there. We just, like I said, the way to think about it is that if you're looking for phase 2, phase 1, other options, and the default option is sacituzumab govitecan if you don't want to do those stacks. So these are excellent candidates for this study.
Yeah, I mean, just to put a fine point on that, we opened it, so I guess that was 6 or 8 months ago, and we were able to find a number of patients where this was a good fit for their wishes. It made a lot of sense to us. So I think for those thinking about it, we were able to open it, prioritize it, open it, and have a number of accruals and offer this option to patients. So it's good in that regard. Any other comments or questions? Okay, then I'm just going to kind of speak freely here. It looks like Olka's our next presenter, and she's online and would like to share her screen if that's possible.
I don't know what to do, okay, if the text don't go to you.
All right, Olka,
Sorry, hang
I
on.
think we can hear you now. Olka, can you hear us? We're just trying to get everything lined up here. Just take a second to give Olka the stage here and allow her to share her screen.
All right. Hi, good morning, everyone. So this is our probe trial, SWOG 1931, combination immune therapy followed by with or without cytoreductive nephrectomy. So this study is obviously trying to look for whether cytoreductive nephrectomy still has a role in the setting of advanced kidney cancer following immune-based therapy. And these are our PIs and Alliance and SWOG champions. So the study design, as you all know, is for synchronous primary tumor and metastatic disease. When patients present with that, start with an IO-based regimen. Any of the 5 FDA-approved regimens are permitted. 10 to 12 weeks scan for response assessment, and then randomize patient if PR or stable disease within 10 to 14 weeks. Things that have come up is if there is pseudoprogression, you can definitely consider if the patient is clinically doing okay, contact me or Dr. Kim, who is the urology PI. And we usually will be able to review the case, and if you clinically think this may be pseudoprogression, we can allow you to proceed with randomization. So step 1, which can be done prior to starting any therapy, you can register the patient, or you can do both step 1 and 2 together at the time after you've completed whatever 10 to 14 weeks of therapy, and at the time patient can be randomized. But remember, there is a ceiling of 10 to 14 weeks. So within that time, that's the time interval you have for randomization, because that's around the time when we would get scans and be able to look at what the patient is doing on the treatment. So then there are 3 possible options. Of course, if there is a CR in the primary, which I don't know when that has happened before, but if it does, then the patient is not eligible for randomization. Or if the patient is just blowing through your initial treatment, rapid symptomatic progression, then they're not eligible. But otherwise, pretty much all the other patients should be able to randomize to either continue on systemic therapy without removing their kidney, or nephrectomy followed by continued systemic therapy. Now, for the nephrectomy, it can be a radical or a partial, depending on the urology input, and the urologist needs see the patient before you randomize, so we make sure that the patient is eligible for surgery. So there is about 4 weeks before that, and then even after you randomize the patient, you have up to 8 weeks to do the surgery, and meanwhile the systemic therapy can continue on. So definitely you have enough time even after you randomize, so don't feel like just because you randomize the patient, the surgery has to be next week. You are asked for a tentative date of the surgery when you randomize the patient. Okay, so far a number of sites have opened it. Thank you very much. And NCORPS, 163 NCORPS have opened it. Accrual to date is 85, but we've actually randomized only 55. So, obviously we all know there will be an additional number of patients who will not make it to randomization. So accrual target overall for this study is 364. SWOG has put on 57. We've done a great job, and please as the studies are opening at all the sites, I mean, I know we opened in 2020, end of 2020, in November, December 2020, and of course, COVID was right there. So the first 2 years, we've had big challenges with doing accrual. But now I think a lot of the centers are beginning to look at patients for this study. So please continue to do that. And with the number of sites open, I think even if every site does 1 or 2 patients, will be done pretty quickly. So these are the sites that have accrued so far, and there are a number of sites that are coming on board with a number of many more patients. So this is the accrual pattern. For some reason we got a big spurt in June and July last year, but then again it dwindled down. So just let's try and keep it at that 4 patient accrual per month, which is where it's headed right now. Thank you very much to all our star accruers. I just wanted to remind everybody that all FDA-approved regimens are allowed. And for the main session, I, of course, have all the accruers, and just a big thanks to all of them, but I definitely want to thank everybody. Even if you put 1 patient, we understand this is not an easy study to accrue to. There is a tremendous discussion around the randomization of surgery or not. It's a big difference between the 2 arms. But at the same time, I want you to realize that no pharmaceutical company is going to do this study, and it is up to us. I think this is the Carmine immunotherapy that we are trying to do in the US, so please participate. Ongoing outreach to sites that have not opened is going on. Patient education video, please feel free to use that. Give us feedback. We can make it shorter. We can make changes to it. There is a CME program that is also videotaped, or one of us can do it in person if you need it, or virtually, if you want at your SIVs, or if you want education for your staff, please, we are available and happy to do that. So there is a CME program also that is available. So with that, I think the most important things I wanted to highlight is this is a patient population that even in Checkmate 214 with IPI and NIVO, median overall survival of these patients who present with the primary and metastatic disease is pretty bad. I mean, it's 26 months as compared to 48 plus months for all comers. So that just shows you already that this is a patient population that we need to make every attempt to improve outcomes in. And this patient population does deserve specific study, which is what we are trying to do in this patient population. And obviously, if you have any other competing studies, pedigree, et cetera, please try and prioritize probe for the synchronous metastatic disease patients, and then the post-nephrectomy patients, you can continue on with accrual to pedigree, et cetera. So please discuss with patients. One of the things that comes up is, patients need to realize that no nephrectomy is the standard, is the established standard based on Carmina results, where nephrectomy did not improve overall survival in the setting of sunitinib therapy. So clearly here with immune therapy, there may be different mechanisms and especially with the neoadjuvant mechanism showing in melanoma, it's a SWOG trial that showed neoadjuvant pembrolizumab was twice as better as compared to doing it adjuvantly. So that tells us that, doing upfront nephrectomy is not the way to go in synchronous metastatic disease. You want to start with systemic therapy and then potentially consider the nephrectomy. So please feel free to contact us, and we're happy to send the video links and CME presentation if you need that for education purposes, or to use for your fellows, et cetera, or for your patients, of course. With that, I will stop and see if there are any questions. Thank you for your attention.
Thanks very much, Olka. I think that came across very well. We could hear you clearly, so that worked really well. Thanks to our AV team in the back for their great support. That worked out great. Olka, one of the questions I heard on this, and maybe you want to go back just a couple slides around the FDA-approved regimens that could lead in. Yeah, I think this slide. I know you've done a lot of work on this, but I just want to make sure everybody sees that. I did hear a question about this. So there's a lot of coverage here for what's allowed.
Okay, yeah, so these are the 5 FDA-approved regimens, and I also wanted to add that Pembro, if you want to use it every 6 weeks, that is allowed also. So that is included in the different regimens. I don't know was there a specific question about any of these regimens, or?
I think what I'd heard before is this new, is it up to date with what's allowed by the FDA and so forth? And I know you've done a lot of work to include these different regimens, and so they're available in the trial, or they're allowed in the trial.
Yes, yeah, any of these are allowed. And that's why the Pembro scheduling, to make scheduling easier every 6 weeks is also an option. And really, these regimens you can treat as per standard of care. So per the package insert, depending on how much initially before the nephrectomy, you have to hold therapy. For instance, for axitinib, it says you can go up until the day prior to surgery versus, cabozantinib, you would need to hold for at least a couple of weeks, maybe longer, when you have the surgery planned.
Great. Okay, so here we are. Looks like someone's coming up to the mic, which is fantastic. Maybe just tap it to see if it's live there.
Hi, Olka. This is Neda from New Mexico.
Yes.
So we have only one patient on this trial. A couple other patients weren't eligible because after nephrectomy, they should have measurable disease, correct? On metastatic sites.
No, at that point, it is not a requirement for measurable disease.
So we don't need to have measurable disease post-nephrectomy.
Yeah, but at the same time, I mean, if you are planning on continuing the treatment, I don't know what. So was the renal primary the only disease remaining?
Yeah. So I had a patient who had amazing response, and everything on metastasis went away. But we thought this patient wouldn't be eligible because didn't have any measurable after nephrectomy. And then, is bone metastasis okay?
Yes, bone metastases are perfectly fine. Okay, by the way, I'm glad you brought that up, Neda, because the primary endpoint of this study is overall survival. So, none of the response and progression is really going to impact the primary endpoint. So that's the good thing. That's why you don't need to necessarily be as much fixated on what kind of progression, when the time to progression is and all of that. But again, that brings up another point that I've had questions about, that if people stop, if the patient progresses on this type of treatment, or if they stop treatment because, like Neda's patient, where they've had a great response and they don't need the treatment any further, then the patient would still be in follow-up even if they've stopped this active treatment. So whether they've gone to other treatment or whether they have stopped the treatment and are just being followed in surveillance, they would still be eligible for continued follow-up for survival. So just to make that clear, because sometimes patients move from one place to another saying, oh, well, now we cannot be on the study because of, now that I've progressed, I'm going on oral agents and I won't be coming here, whatever. But keep in mind that that patient is still eligible for survival follow-up, as long as the patient is okay and they're not withdrawing consent.
Great question. Thank you for that question. I think there's one more online. And so, Dan, if you can hear me, I think you just have to type it out. So I'm going to read this to the group. He said, can you discuss the regulatory requirements for nephrectomy? Does it have to be at IRB-approved sites? Also, does urology have to be a sub-I? Any correlatives? So the first one there is, does the nephrectomy have to be at an IRB-approved site also?
Yes. So right now we are saying that the nephrectomy and, the urologist should be either co-investigators or at least at a SWOG-approved site. It should be done with a SWOG credentialed urologist. But it is fairly easy if you are already a site within SWOG for the urologist to get credentialed. But yes, it is a required thing. And clearly that urologist, and there can be assists from others, but there should be at least one urologist in the OR who is SWOG credentialed.
Thanks, Olka. And that last part of his question was any correlatives that you wanted to mention on this study?
Yes. So there are a number of correlatives. There are some, of course, we are collecting tissue and blood, and we're banking that as well as planning genomics sequencing around this. The other unique thing is there's going to be a radiomics. In the imaging committee today, there was presentation about radiomics that will be done. Interpreting immune response is always a tough thing on CAT scans, and there are mechanisms to figure out better who is responding or who's benefiting. And we also plan on testing some immune angiomarkers and biomarker sets that are being developed right now. So yes, there is a ton of correlatives. There's going to eventually be a patient-reported outcomes that will be, our SWOG Young Investigator Award was given to Dr. Bergero, who has incorporated some PROs that we will also be including in the study eventually.
Some great questions. Yeah. Thanks. Any other questions in the room here? And frankly, let's just open up to questions for any of the three trials.
I can add something about SWOG 1937. There are patients that the question of bone metastases came up. If your patient has bone-only metastases, again, they're allowed in SWOG 1937. They don't have to have measurable disease if bone is the only site of involvement. That's
okay. So same thing as probe. Also, I was going to ask if Pedro or Shuchi, we have some star accruers in the audience, if they want to share any tips for what works best or how they think about, since they've accrued so many patients and been successful at it, I would just like if they would care to comment on their tips.
Hi, Ulka. Nice to meet you on the virtual platform. But I think the biggest thing that's worked for me, and hopefully it'll continue to work, is to engage the urologists. Like in Cincinnati and now at UC Davis, the referrals are coming from urology. So their buy-in has been extremely helpful. And then I think the second thing also, because there's multiple steps that you can register these patients on, is to continuously talk about this trial with the research coordinators and just keep bringing it again and again to everybody's attention. So I think those two things have really helped. But yeah, urology buy-in is very essential for a trial like this.
Great comments. Thanks so much.
That's a great point, Shuchi. And maybe one of the urologists would care to comment, Brian or somebody.
Pedro's just stepped up to the mic as well. Pedro, do you want to go
Brian
first?
is more important as a urologist. Go ahead.
So I enrolled our second patient yesterday. It took us a long time to open, but I think if the urologist buys in and says, listen, I'm going to do if you're randomized to surgery, I'm going to do your surgery, but if you ever get into trouble with hematuria, significant pain, I can always reconsider surgery down the road. It's nothing that says you can never have surgery. And I always warn them, I don't know what's going to happen when you go off therapy. You could progress, and I'm worried. And if the urologist has buy-in and says, I don't know if I'm doing the right thing for you, and you let them know that they could potentially down the road, if they really need it, can get surgery, I think that there's a substantial buy-in.
That's a good point you bring up, Brian. And honestly, in my 11, 12 patients that we have registered, one patient has had to go back and get nephrectomy because after he progressed on the initial regimen and had a ton of hematuria. So it's not very common, but it can be required later on.
Yeah, if I just may add briefly, I completely agree with others' comments. It's a very, very important study that I think we should all, back up and make it happen. I think it's important sometimes to highlight that we actually have two chances of enrolling patients, step 1 and step 2. Personally, I prefer to enroll them in step 1 because as soon as they start on IO, they're already enrolled and, and we're helping. But we also have a second chance, right? Post the neoadjuvant part of the induction period of the study, we can have the step 2. I would say that, for folks who already started, let's say, any IO based for 2-3 cycles, they can still get the chance to be on probe. That's an important one. Urology, absolutely. I think the cell is actually not difficult. This is now my second institution, and we got I think we got 10. And what to Ulka's point, The difference, the way I read the difference between patients enrolled and patients who actually randomize is because some of them, there's a pickup of enrollment. There's people go through the induction, and we got to wait until they get to the randomization. But as I was saying with urology, it's my second institution where, I find urologists have a buy-in and really like the concept, and where I think we have like 3 up to 4 at Case, and we had like 10 at Tulane. So I think working together with urology makes a big difference as well. Again, it's a very important study. And the last thing I'm going to highlight is some of the sites might face a potential conflict with other studies in this space, but I have to say that, the other options in frontline are, the 2 randomized phase 3s that I can think of are almost done. And there's an NRG study coming on board, but I don't think it will conflict with this one, because if you have a primary mass, we do understand the role of, we do understand for symptomatic purposes on one hand, and on the other hand, in a case that patient is not interested in surgery, then the NRG study could be an option. But otherwise, I would prioritize probe in those patients. So I just want to say that is a perfect study right now in the kidney cancer arena, and I really think we should support it and make it happen.
Great comments, and we're nearing the end of our time today. We're planning to start the other session at the top of the hour. I just look to Guru, Sarmad, and Okla to see if there's any last comments you'd like to make in closing here today. Guru, anything you'd like to add with your trial?
Well, I guess my last comment on the GAP trial, the neoadjuvant gemcarbo-avelumab for upper tract and bladder, is that it's highly inclusive. There is no central PD-L1 testing. We don't mandate anything adjuvant. So it's the easiest, most inclusive neoadjuvant trial I know of in the cisplatin ineligible space, and allows bladder and upper tract, which is not the case for most neoadjuvant trials either. They focus on bladder or upper tract. So please consider this GAP trial.
Sarmad, any comments? Any last-minute comments?
Well, I think I said it at the outset. These studies, without the support from all of you, they're not going to succeed. We need patience. So please consider opening the study at your site.
And Okla, a great presentation here and engagement. Any final comments from you?
Okay, so I would just like to say that a huge thanks to everybody who has gone out of their way, even in the midst of COVID, and opened the study in the first place. So many centers have done that, and huge thanks to you guys. And please keep going. I would say just that it is important to remember that, this is the VEGF-TKI and IO combination study, because, Pedigree and other studies require you to treat with ipi-nivo. And I think a lot of patients now we are treating with upfront VEGF-TKI and IOs for metastatic kidney cancer. So please keep that in mind and remember and support PROBE. Thank you.
Well, thanks, everyone. Thanks to our 3 presenters and for the audience participation. We'll kick things off with the main program here in just a couple of minutes.